All right, let's play a game. Which one is more stressful, high-dose corticosteroids or nursing school? Well, the answer is yes. These are both pretty stressful. But if you've been panic studying for the NCLEX with cortisol running through your veins, then this video is for you. I'm Dr. Emily, and today we're breaking down Cushing's and Addison's disease, one of the NCLEX's favorite endocrine targets. So first, the big picture. Your adrenal glands sit like little hats on top of your kidneys, and these produce hormones that regulate stress and immune response, metabolism, and fluid balance. The middle of the gland, called the medulla, makes catecholamines or adrenaline, which includes epinephrine and norepinephrine, which are your fight or flight hormones. And the outside, the cortex, is where all the drama of Cushing's and Addison's happens. That's where we produce androgens, or our sex hormones, and corticosteroids. And our corticosteroids include glucocorticoids and mineralocorticoids. And glucocorticoids, or cortisol, the stress hormone, suppresses inflammation and immunity and raises glucose to help fuel all that stress. This is why you would always get a cold during finals week, because those high cortisol levels suppress your immunity. And aldosterone manages fluid and electrolytes, especially sodium and potassium. Because remember, your adrenals sit on your kidneys, and aldosterone works in the kidneys to retain sodium and water, because water follows salt, and it does this in exchange for potassium. So we retain sodium and excrete potassium. So if you have too much or too little of these corticosteroids, everything goes haywire. So let's line up Addison's versus Cushing disease side by side, because the NCLEX loves these comparisons, especially in select all that apply questions. So Addison's disease is too little cortisol and aldosterone, and Cushing's is too much cortisol and aldosterone. So these are going to create opposite problems, where patients with Addison's appear dried up and patients with Cushing's appear puffed up. So in Addison's disease, because aldosterone is low, we lose sodium and water. So BP and volume drop, and potassium goes up. That fluid loss and the lack of stress hormones will cause weight loss, and then our glucose will be low because we lack cortisol to fuel our stress response. Then Cushing's is the opposite problem, where because we have excess aldosterone, sodium and water are retained, so BP and fluid go up and potassium drops. And our glucose and weight will be high because our stress response is in overdrive. Now, let's look at each of these more specifically, starting with Addison's disease. Addison's disease, aka adrenocortical insufficiency, is a deficiency of our corticosteroid. And this is usually caused by an autoimmune or malignant destruction of the adrenal glands. And because the adrenals are destroyed, we can't make cortisol and aldosterone, which impairs our regulation of fluid, electrolytes, and glucose. So what findings will we see? Well, remember, these patients are all dried up and they don't have an adequate stress response. So because of that low aldosterone, we'll see a low BP. Because of that low sodium and fluid volume, and K will go up. And because of the low cortisol, we can't keep our glucose up either, so we have a low glucose and a low weight. And another classic finding is bronze skin. That's because your pituitary gland keeps shouting, make more cortisol, so it cranks up ACTH, but ACTH also triggers melanin production, giving the skin a tanned look. And fun fact, President JFK's famous bronze tan was actually just from his Addison's disease. And so if Addison's disease is a deficiency of corticosteroids, our treatment is to give lifelong corticosteroid replacement therapy. So we should plan to give steroids as prescribed, such as hydrocortisone and prednisone. But for any patients taking steroids, remember to use the acronym STOP for your patient teaching, which stands for sugar, taper, osteoporosis, and prevent infection. And because these patients depend on their steroid replacement therapy to suppress their stress response, don't forget that they're going to require an increased dose during times of stress, like infection, surgery, or after trauma. We also need to address their risk for fluid deficit, hyperkalemia, and hypoglycemia. So for fluid deficit and hyponatremia, be sure to monitor their blood pressure, ionos, and daily weights, and increase their sodium intake. And for their hyperkalemia, as for any patient with a potassium imbalance, they should be placed on continuous cardiac monitoring if they're hospitalized. And we also need to be on the lookout for the life-threatening complication of Addison's disease called Addisonian crisis, or acute adrenocortical insufficiency. You might also hear this called endocrine shock, same thing for myxedema coma in hypothyroidism, because this is a life-threatening state of shock, hypoglycemia, and hyperkalemia. And this crash is usually caused by a sudden withdrawal of their steroids or acute stress like infection or surgery when the body just can't compensate. So this is why they should be taught to never discontinue their steroids abruptly, but that they should instead gradually taper off. That's the T in your stop mnemonic. You should also teach them to wear a medical alert bracelet so that if they're found unconscious or in a trauma, the providers know to continue dosing their steroid replacement therapy and to increase the dose to accommodate all the extra stress. And of course, the best thing to do is to avoid Addisonian crisis in the first place by reporting any infection promptly so their provider can bump their steroid dose temporarily, and teach patients to avoid triggers like strenuous exercise or stress. But of course, the priority intervention to look for on the NCLEX, if your patient comes in with endocrine shock from acute adrenocortical insufficiency, is to address the underlying cause, which is a steroid deficiency, by treating with IV corticosteroids. So for your first NCLEX quick check, pause and take a moment to answer. All right, how does Addison disease affect weight, BP, and appearance? So remember, with Addison disease, we're losing salt and water. So these patients are going to have weight loss and a low BP, and they're going to have that bronze skin hyperpigmentation from their increased ACTH, increasing melanin production. Next, what is the treatment for Addison disease, and what should you teach clients about it? Well, remember, if this is a steroid deficiency, we need to give them lifelong corticosteroid therapy. And in addition to your stop teaching points, teach them to not stop it abruptly, or this could trigger Addisonian crisis. And finally, what are the signs of Addisonian crisis and how do you treat it? So this is going to look like endocrine shock with hypotension, hypoglycemia, and hyperkalemia. And we need to treat the underlying deficiency by giving IV corticosteroids. Great job. All right, now switching gears to Cushing syndrome, which is the hormone overload version and features glucocorticoid and aldosterone excess. This can be caused by a tumor secreting excess glucocorticoids called Cushing disease, or by long-term steroid use for something like COPD or rheumatoid arthritis, and then it's called Cushing syndrome. But the picture is the same. Too much cortisol and aldosterone impairs our regulation of fluid electrolytes and glucose. So this gives us that puffed up overstressed picture where too much aldosterone increases their blood pressure, sodium, and fluid volume, but gives them a low potassium, and too much cortisol causes hyperglycemia and weight gain. And specifically, excess cortisol causes a unique pattern of weight gain where fat is redistributed to the trunk, face, and back of the neck. So visually, you'll see truncal obesity, moon face, and a buffalo hump. Cortisol also breaks down collagen and impairs wound healing, causing thin, fragile skin and poor wound healing. And this is one not to forget since skin integrity is a huge focus of nursing care and therefore the NCLEX. So our goal for treating this steroid excess is to bring those steroid levels back down by discontinuing the steroids that they're taking them, but don't forget to gradually taper them or you could wind up throwing them into Addisonian crisis. You might see adrenal suppressing meds like ketoconazole prescribed to suppress cortisol secretion, or they might need chemo or surgery if that excess steroid secretion is coming from a tumor. But just remember, if you see Cushing's from chronic steroids, the answer is to taper slowly, never to stop abruptly. And this steroid excess puts them at major risk for a few things, specifically risk for fluid overload from the sodium and water retention, risk for infection because cortisol suppresses immunity, and risk for injury because they have poor wound healing and probably osteoporosis. And what are we most concerned about in patients with fluid overload? That's right, too much fluid in the lungs or pulmonary edema. So in addition to monitoring BP and daily weights, we should also watch out for signs of dangerous fluid overload like a bounding pulse or crackles in the lungs. And to keep them from retaining even more fluid, you should place the client on a sodium restriction. And again, if they have hypokalemia, we need to implement continuous cardiac monitoring while they're hospitalized. And to prevent infection and injuries like falls and skin breakdown, you should have fall precautions in place, turn them regularly and monitor for signs of skin breakdown, and teach them infection prevention measures like hand hygiene and staying up to date on their vaccines. For your next NCLEX quick check, pause and take a moment to answer. All right, how does Cushing syndrome affect weight, BP, and appearance? So remember, in Cushing syndrome, we have too much cortisol and aldosterone, we retain salt and water, causing weight gain and a high blood pressure, and we're going to see fat redistribution to the trunk, face, and back of the neck, causing truncal obesity, moon face, and buffalo hump. And how should you monitor and treat fluid imbalance in Cushing syndrome? Well, remember, Cushing syndrome is going to cause fluid retention, so we should monitor daily weights and assess for those dangerous signs of edema, crackles, and a bounding pulse. And we can limit their fluid retention by limiting their sodium intake because water follows salt. Great job. Now let's talk about Conn syndrome. This is aldosterone excess caused by an adrenal tumor. Conn is like Cushing's quieter sibling, so only aldosterone is up. So we'll see the same BP and potassium issues as Cushing's, but no glucose or weight gain, plus metabolic alkalosis from hydrogen ion loss. So this means our assessment findings will include an increase in blood pressure and fluid retention, hypokalemia, and metabolic alkalosis since we've lost hydrogen through the urine. And our interventions should address this overload by monitoring their BP, fluid, and electrolytes, cardiac monitoring if they're hypokalemic, and to correct the underlying cause, we can give spironolactone, which acts as an aldosterone blocker in the kidneys, and replace their potassium by giving potassium supplements. And they'll eventually need an adrenalectomy to remove that tumor. And our last one is an exciting one, and that's Pheochromocytoma, which is an adrenal medulla tumor that releases bursts of catecholamines. So these sudden sporadic surges in epinephrine and norepinephrine can cause rapid, severe increases in blood pressure and heart rate and can be a cause of hypertensive crisis. So for our assessment findings, it's going to look like you just pushed a bunch of epi. Your patient's going to have severe hypertension, palpitations, and tachycardia. And here is your NCLEX trap. Do not palpate the abdomen for the tumor. Pressing on that tumor could trigger a hypertensive crisis. I once saw this in a pregnant patient, and her belly pressure triggered these episodes of hypertension. So trust me, don't palpate. Instead, you should monitor their blood pressure and heart rate closely, give beta blockers to block the effects of all that adrenaline, and anticipate an eventual adrenalectomy to remove the catecholamine-secreting tumor. And for your final NCLEX quick check, and this should be an easy one, what action should you avoid in clients with a pheochromocytoma? And that is, do not palpate the abdomen unless you want to give them a hypertensive crisis. And now you're ready for Cushing's and Addison's on the NCLEX. Thanks for joining me.